welcome to everyone joining this virtual symposium, either live or later on recording. I'm David Chang, and I'm proud to welcome everyone to the fourth annual CyberSight Cataract Conference, dedicated to our dear colleague, Alan Crandall. Alan, as many of you know, was a prominent cataract and glaucoma surgeon, a past president of ASCRS. But unique to Alan was the fact that he is the only individual who's won the Humanitarian Award from AAO, ASCRS, and the American Glaucoma Society, all for his dedication to global ophthalmology, in particular to teaching people around the world to enable them to be better surgeons. This is the fourth time we've done this. This was the brainchild, the suggestion of Orbis medical director Hunter Cherwick. And the idea is to take some of the leading faculty around the world and to have them participate in a case-based discussion. So we'll have cases followed by panel discussion. And one thing we always try to do is to leave at least 20 minutes at the end to discuss questions posed by the audience. You can pose the questions throughout using the Q&A function on Zoom. And please don't be shy about posting them, and we can sometimes answer some that are quick during the session, but otherwise we'll leave room for panel discussion at the end. Now, I'm particularly excited with the faculty that we have this year. Each of these individuals is well known not only as a gifted surgeon, but also really for their teaching prowess. And they include Dave Crandall from Michigan, Tom Oetting from University of Iowa. Tom was the first recipient of the ASCRS Teaching Award. Bonnie Henderson from Massachusetts, who was the originator of the Harvard residency course program. Bruno Ventura from Recife, Brazil, who leads the resident education there and has also organized resident courses. And then Kevin Miller from UCLA in Los Angeles, who leads the Los Angeles UCLA residency course. So we have just a dynamite lineup for you today. So we're going to start with the first presenter. Will be Dave Crandall, and Dave will also say a few things about his father, Alan.
All right, welcome everyone. First I want to thank David Chang and Hunter Cherwick for putting this together, and Lawrence for keeping everything organized and running smoothly. This meeting is really special for me because it really cements Dad's legacy. His big thing was that he not only wanted to be a great surgeon, but make everyone around him a great surgeon. And for him, those around him included ophthalmologists all over the world. If you were an ophthalmologist, you were part of his inner circle, and he wanted to make you better. And I think everyone he interacted with was a better surgeon after being with him. I know that's true for me, and I've been watching cataract surgery with him since I was 4 or 5 years old. So with that, I will go into my case here. So this case is a 41-year-old who came with left-sided eye pain to our resident clinic. He had a history of high hyperopia in the range of +12 to +13. He'd had LPIs performed when he was 12 years old, and he's a musician, and he noted for some time he'd had left-sided pain and halos whenever the lights went down during concerts. Best corrected acuity was 20/60 and 20/40, and his pressure was in the upper 40s in both eyes. Next slide. He had a sister with similar eyes, and years ago she'd had urgent surgery for high pressure, and in his words, it didn't go well, but he didn't know the details of that, and she'd had at least 8 subsequent surgeries in that eye. Next slide. So he had a very shallow anterior chamber of spherophakia. His pupils were 2 and 4 millimeters. B-scan showed a short eye with thickened sclera. His pain did improve with medical management, and his pressure came down to the mid-30s. His corneas are in the 700 range, so there is some overestimation of his pressure. Macular OCT showed some thickening, and 2 days later, his pressure was back up into the 40s with pain and microcystic edema. Atropine was added to deepen the anterior chamber. Next slide. So his measurements, so under 16 millimeters length in both eyes. The anterior chamber depth on the eye, well, Master said 2.85 and the Argo said 1.59. I'm going to show a picture to show why both of those are wrong. Pretty steep corneas, very thick lenses of 6 millimeters, especially for a 41-year-old, and a fairly normal white to white. Next slide. So here's the Argos image, and I would argue that that's not 1.5 millimeters anterior chamber depth there. So next slide. So the pre-op plan, obviously, we had a long discussion about the risks. We do have the lens limitations in the US that 40 diopters is our limit. Our calculations predicted a 54 diopter lens to get him to emetropia. We're planning general anesthesia. Obviously, we don't want to block and increase the posterior pressure. A Honan cuff, we put it on pre-op, and then mannitol. And then actually, so the next slide's the video. So now's a good chance to get the panelists to see what they would plan going into this and what we want to look out for.
Sure. Quick question, David. Really difficult case, even preoperatively. Is there amblyopia with him too? From all of this?
His best corrected historically was about 20/40 according to him. So there may be some component of that, but also that could be from macular issues or any other developmental abnormalities. I don't know if it truly counts as amblyopia. He started wearing contacts when he was about 1.5 years old.
And he is able to wear contact lenses still
Yes.
after the surgery, possibly?
Yes.
Okay, great. So
Yeah,
I mean, go ahead.
These spherophakic eyes, sometimes they'll actually, the crystal lens will end up in front of the iris, wedged between the iris and the cornea. In fact, we had one in the emergency room just last week. So they present as emergencies. Sometimes the pressure will be 70. And as you know, you don't have a lot of space to work in. And at least you have some space. That's great because lens is not against the cornea. So you don't necessarily have to go straight to a vitrectomy to create space. I think I would try to avoid that here. But if you don't have any space, that's one of the early steps of the procedure will be to create some space. And you'll have a lot of space to work in even to get your vitrector in there. So it's a touchy situation.
Dave, in these very, very short eyes, do you already go to surgery planning to do a decompression of the vorticus veins, or you see if you need it?
So I do scleral windows in this case, not direct decompression of the veins, but I do scleral windows.
Okay.
So just a couple follow-up questions for the panel. Many of the viewers general anesthesia may not be so easy to do. And would you feel that a retrobulbar or some type of periocular regional block would be sufficient or adequate? And then Kevin, maybe I'll have you comment on, the technique of pars plana vitreous tap, and when should you not do that in terms of potentially non-ophthalmic eyes?
Yeah, so for the block, these are small eyes and you have a lot of space behind the globe to get a needle back. So I wouldn't be concerned about doing a block in such an eye. I have found in many of these eyes, I've not needed to do scleral windows. If you can keep the intraocular pressure elevated, I think you'll find most of the time you're not going to have to deal with choroidal effusions. So I've pretty much never had to do cut downs. I prefer not to go into the vitreous if I can avoid it. If I can get a millimeter of space in the anterior chamber, I will work in that space. As soon as you get the capsulorhexis done and you start taking out the cataract, you create space as you're removing the cataract. So you quickly get space where you don't start off with a lot of space. And of course, you'll use a lot of dispersive OVD to make sure you're protecting the cornea the entire time. I'm more thinking of what's the lens going to look like once I get the cataract out? Can I preserve the capsule? The zonule is going to be shot. Do I need to plant a capsule tension ring? Almost all the time in these eyes you do. Do I need a capsule tension segment to secure that capsular bag to the sclera? So if I'm going to do a capsule tension segment or two of them, I'm going to pre-plan Hoffman pockets so that I have something to secure the rings into. So those are the things I'm thinking ahead of time. If you have to do a pars plana vitrectomy because there's just not enough space, then you want to go about 3, and it's decent ophthalmic guys, you want to go about 3 millimeters posterior to the limbus with your MVR blade, and you want to aim towards the optic nerve. Do not want to ding the lens and make a mess out of it.
It's really challenging here because this is not a normal lens and it's spherical.
And also the pars plana is not where it is in a normal eye. So you do, even at 3.5 millimeters back, you risk going through the retina rather than pars plana.
Mhm.
Bonnie, Bruno, would you do mannitol in a situation like this?
Sure. I definitely would do mannitol. And Kevin really highlighted some of the important thoughts. Let me just add to that list too. One of the things I'd be most worried about is intraoperatively managing the iris, because I know that with such a short eye and a lack of space, it's going to be really important to create the architecture of the incision very well in order to have more of a self-sealing. Oftentimes, I prefer not to be in the cornea, and I'll do more of a limbal or a scleral tunnel just to give myself a little extra space away from the iris. And then also know that you're going to use a gallon of viscoelastic most likely to try to protect the cornea often, and you are probably going to have to manage an iris prolapsing quite a bit. So I think mannitol is very, very helpful. It's useful in many situations, especially in this situation with such a short axial lane.
All right, we can go to the next slide with the video. So for me, with his history and his family history of his sister having issues, that as we dug down into it more, it sounds like she did have effusion issues and he did already have choroidal thickening. I felt better doing scleral windows. I originally wanted to do a 5x5 window, but I didn't have enough space between his muscles. So I ended up doing about a 4x6 millimeter window. And these, basically I'm trying to get down to where I see blue. And if I have a little spot there anteriorly, you can see I went full thickness, which doesn't bother me because it's just one more area of decompression. And I did a second one supratemporally. This is a very long, very anterior tunnel just to give me space. And then using that first gallon of viscoelastic just to deepen things up. Now I can make a more traditional paracentesis. Any complicated case, I always make 2 or 3 paracenteses no matter what. Since I wanted to keep him as pressurized as possible, and a lot of times these young spherophakic patients, the rhexis wants to run out, I like doing it through the paracentesis because that keeps everything nice and deep, and the micrograspers work very well for that. And even with that, this still wants to run out on me, and I won't say it's the longest time I've ever spent on a capsulorhexis, but it's usually these are the cases that I spend the most time doing that. And I didn't show it, but I did stain with Vision Blue. I like to do that in young patients to help make that capsule a little more brittle. And also with these tough cases, it lets me easily see my rhexis edge when I need to use hooks or OMED segments or anything else. I just like the extra visualization. And anytime I have a very abnormal eye, I prefer to do that. And while it does look like there's a lot of blood on the field, he didn't exsanguinate through this eye. And then I also did my hydrodissection through my paracentesis. You do have to be a little bit careful doing that. You don't want to overinflate. And I felt that he was young enough and this lens felt soft enough that I could just use the bimanual INA to remove most of his lens. And so at this point, I actually haven't even created my my primary incision. As Kevin mentioned, keeping everything pressurized. So every time I come out of the eye, I put viscoelastic in before I stop my infusion. And then we just sort of visco-dissect what's remaining of that lens up, and again, taking our time, slowly removing it. Since he's under general anesthesia, I feel no pressure to do this case quickly. And I did notice it's subtle, but when I was removing the nasal cortex, there was a little bit of zonulopathy on that side. And the capsule sort of snaps in and then snaps back out. And deepen everything up. I always sweep the capsule. Even in young patients, it's amazing how much crud we clear off from the anterior capsule. And then, as mentioned, I even without that zonulopathy that I noted, I would have done a capsular tension ring. I usually, in complicated cases, I like to feed it in manually. I feel like I have good control. I have good tactile feedback for where that is. And I make sure I'm not putting too much pressure on anything, and let's drop that in. And just cleaning up whatever remaining cortex. And so actually now I'm making my primary incision. So without my main incision, I was able to keep everything nice and deep and keep everything pressurized throughout the case. Since this is a 40 diopter lens, we had to use a B cartridge and make the incision a little bit bigger than I normally like to. This is the one situation I do that. And then also with his sister's history, and he's at high risk, I was worried about intraoperative, but also postoperative aqueous misdirection. So I'm doing a iridozonulohyaloidotomy with the vitrector. And then I did also do some goniosneculisis. The PI did end up a little larger than I normally like to make it, but I wasn't too worried about that. And thankfully, he did not go into aqueous misdirection. So he actually saw him about a month ago. He's 20/30 best corrected. He actually, even with only a 40 diopter lens, he was about +6, which is the best he's seen since he can remember. So it's still an improvement of where he started. And he has had intermittent choroidal effusions. Early on, we did have him on oral steroids with the retina service. And his retina stays relatively flat. He's been on prednisolone 1 drop a day. We cut him down to every other day. He starts to get a little bit of macular thickening again. So but he's been tolerating that well. And this is now, it's about 2 years out. Thankfully, his other eye has no PAS and his pressure's maintained in the low 20s in both eyes.
Super.
All right, so we can go to the next slide. So, like I say, I like doing the scleral windows since I'm a glaucoma guy. I'm comfortable digging into the conjunctiva and the sclera. Capsule staining, I mentioned keeping the anterior chamber pressurized. I like to do the hyaloidotomy. In normal cases, I like to do it from the pars plana, but this gets back to that issue that we don't really know where his pars plana is, so I was preferring to avoid sticking anything behind the lens from posterior, since we can't trust those normal landmarks. And in most small eyes, you don't need all of these techniques, but any one of them can be useful at any time. And Kevin, you mentioned the Hoffman pockets, which I think are a good idea. With him, since I opened his conjunctiva all the way around for the scleral windows, I wasn't worried about just directly suturing something if I'd needed to.
Mhm.
Dave, that's a great case. Can you just expand for the audience on the IZAH and
So the
you're doing?
iridotomy, zonulotomy, and anterohyaloidotomy. So for malignant glaucoma or aqueous misdirection, depending on which term you prefer, to break those attacks, you need a unicameral eye. And so going in peripherally through the iris, through zonule, and through the anterior hyaloid, you create that unicameral eye, and so you'll break those attacks and prevent future attacks, which is what I was most worried about in his case. Thankfully, his eye behaved intraoperatively, but there was a risk of that postoperatively.
And you're doing
and
that.
later on, I did learn that that was both choroidal effusions and aqueous misdirection were both issues that his sister dealt with postoperatively. So I find these apples don't fall far from each other when they're coming off the same tree. I was going to say, in an urgent situation, I like to do these with a vitrector, but an urgent situation with an MVR blade or even a 30 gauge needle, just at the limbus, straight posterior, you can go through iris, through zonule, and into the anterior hyaloid space. And we've done that in the clinic, and I've done that in other cases intraoperatively.
Super. And then let me just ask the panelists, how do you diagnose a suprachoroidal hemorrhage, and are there any things you do in advance or to prepare for that possibility?
Sure. So, this patient is under general, so you can't really rely on the pain, which is oftentimes our telltale sign when we're doing cataract surgery. So, a couple things. I think the hardening of the eye, the unusual movement of, the anterior movement of the iris, diaphragm also. And, if you see a dark shadowing, that's always also a very worrisome and scary sign that you see. I think those be very vigilant to look for those types of signs. I do think that mannitol is really, really important in this case and many others to really try to soften the eye and hopefully decrease the risk of having issues intraoperatively. But I also think that pressurizing throughout, as David said and Kevin said as well, is going to be really very important. And just keeping, being aware of everything that's going on besides what you're using in your hands, I think is really important in a very complicated case like this.
I don't know that these eyes are at increased risk of suprachoroidal hemorrhage. They certainly are suprachoroidal or choroidal effusion. But yeah, as Bonnie says, you don't have the number one sign, which is patient starts to complain of pain and you got a good block. So you just have to, these eyes, the iris is already trying to come out the incision the entire case. So you don't really have that as like an additional thing to look for because it's happening anyway. So you just have to be super vigilant. And if you suspect it, close up the eye, put on indirect ophthalmoscope and look, I probably would not do the iridozonulo hyaloidectomy as a primary procedure. I would warn the patient that they're at high risk for that postoperatively, but rather than to further complicate an already difficult surgery, I would just tell them there's a chance you may go into aqueous misdirection postoperatively. Your iris may be back against the cornea. And if that happens, then we'll have to go back in subsequently and do that subsequent procedure. But I've only had to do it once or twice in my career, and I've done, dozens and dozens of these small eyes. So they don't all automatically go into aqueous misdirection. So that's one thing I would just stage rather than do primarily.
Yeah, I think that's not unreasonable. I just felt with his sister's history, I was more comfortable with it. And I talked to him about it beforehand, and it was easy enough for me to do while I was in there and he was asleep.
Great. Well, David, thank you so much. That was an amazing case. There are a number of questions that I think we can circle back to at the end. But at this point, I'd like to introduce Tom Oetting to present his case. And again, for the audience, please just type your questions, comments, and we'll try to answer them throughout.
Well, thank you, David. I'm so excited and so honored to talk about a case that I think would be of interest to Alan. In 1997, the very first thing I did when I came on faculty was I told my chairman, I said, I need to take a spy trip to Utah. And I wanted to see this famous guy, Annual Crandall, who was known for teaching, and he was also really known for teaching teachers. And I spent a whole week just watching him, just kind of sat in the corner. And David, your dad was so nice to me, and he just tolerated every stupid question I had. And every time I went, oh, wow, look at that. Oh, that's amazing. All these sort of things I was doing with him. And so it's an honor for me to be here. And what I want to talk about is a case that I think that Alan would be interested in. And it's not the typical case and nowhere near as sexy as David's last case. Let me just... So here's the case that I think happens very much in my practice, and it's these forgotten patients that are sort of in an institution somewhere. They're in some residential facility. They've got cataracts in both eyes, and nobody wants to mess with them. There's so much trouble. They're hard to examine. They're difficult to get to clinic. They often don't have family with them. They don't have caretakers. And then somebody will sort of get up the nerve to bring them to the clinic. And I just love taking care of these patients because you can do so much for them. You can really take somebody that's very dysfunctional and make them more functional. And they're not seeing 20/15 OU with a multifocal lens, but they're able to see their meals, or they're able to see what's going on in the space around them. And so that's what I want to talk about. And when I think of Annual Crandall, this is the kind of person he would fight for. in my opinion. This is the kind of thing that he would want to do. So that's what made me think about these cases. So this case that I'm going to tell you about is typical of that. And it was a relatively young person who lives in a residential facility. We weren't able to get any exam at all, just uncooperative with exam. But the people that were with this this person thought that they had less function. They weren't able to get around as well. They were sort of hugging the wall. They weren't enjoying the TV. We weren't able to get any data really. And so in that situation, the thing to do is to quickly say to yourself, okay, we're going to have to do an exam under anesthesia. And this is hard, I know, for some people to do, but it's the key here is just at some point you just punt and you say, you know what, we're not getting any good data. We're going to have to do this under anesthesia. In order to do that, you've got to find somebody that has the power to allow that to happen. So there's some medical power of attorney somewhere. And this is the sort of persistence and grit that we learned from Alan, right? This is going to take some muscle. We have to find somebody somewhere that's got the power to allow us to do this. And so I wanted to show a picture of our chief residents, because those of you that know me know that my first course was to tell one of these chief residents, get this job done. And for this particular case, I believe the woman on the left on the top left is the one that got this job done and was able to find the parents that had the power of attorney and would allow us to do an exam under anesthesia. But more importantly, we also got a consent to do both eyes. And this is what I think is important in this situation, because I want to talk about the idea of being able to do both eyes once you're asleep. And so we talked about the idea of doing the exam anesthesia and being able to do both eyes because we were sure there was a cataract, but we weren't sure what else was going on. We also knew that putting drops in was going to be really tricky, right? It's not going to be easy in this patient to get drops in. The patient's going to fight. It's going to be a real traumatic experience getting drops in. So we have to figure out a strategy where we don't have to use drops postoperatively. And we don't want to do general anesthesia more than once. Because the last time this patient, like 10 years ago, had general anesthesia, it was tricky. The airway was tricky. So what we want to do is come up with a strategy where we only do general anesthesia once. So we do both eyes if we can. We want to come up with a strategy where we can not have drops afterwards. So that's our mission. Any comments on that from our panel?
You're right.
Yeah, I love the
Good.
yeah, I love the holistic view of the patient and not just the ophthalmology. And I think that that's a really great case to actually think about how to take care of this patient completely and not just the cataract. So I agree with everything you said, as always, Tom, actually.
Yeah, right. Well,
My biggest concern for these, what I call them headbangers, is that, it's not just getting the eye drops in, it's keeping their hands from doing this, and messing up your great work, the moment the patches come off or the moment they wake up. So you almost have to do a chemical restraint on them for like days and have somebody around the clock watching them, almost restraining them to keep them from injuring their own eyes postoperatively.
well, I think that's a great point, Kevin. And that is one of the decision points for us was, if we think the patient is going to be a real eye rubber, then we typically will only do one at a time. But if we feel reasonable confidence that the patient doesn't at a baseline rub their eyes, then we'll often do both eyes but place a suture. But you have to be careful with the suture because you don't want to remove that suture. So you got to do it in a clever way. So let me just tell you about the next day we saw the patient. We took him to the operating room and we did the EUA under general anesthesia. I know that's hard for everybody to do, but that's what you have to do. The anterior segment exam was unremarkable. We did keratometry with a portable device. You can use a contact lens as well. You can place a contact lens of a known power, and you can see if it's the cornea is flatter or steeper than that. That's another way you can do it to get in the ballpark. Do an A scan in the OR. We did a B scan as well because we couldn't see. We hadn't been able to see the back. And so both eyes were normal. So if one of the eyes would have had an RD or one of the eyes would have had some pathology, we wouldn't have done that eye. And so, but we had the consent for both eyes. We weren't sure which eye we were going to do. It makes the nurses nervous. You say, which eye we're going to do? Well, we don't know yet. We're going to either do both or one or the other. We're going to decide. It makes everybody really nervous, but you do the right thing and you're consented for everything. So in the OR day, we decided we were going to do both eyes because both retinas look normal. Both optic nerves look normal with ultrasound. And I'm always telling the residents, -1 is a great place to be because, you know, -1 is awesome. You're a little bit nearsighted. You can see your cell phone. You can kind of read. You can see 20/40 to drive. If your world of make-believe is sort of your table and your food, which more and more that's my world of make-believe. That's what I love the most is my table and my snacks. The -1 is a wonderful place to be. And so that's where I put folks where we can't talk to people, where you can't reasonably communicate with people what the goal is. This is where I think is a good place to be. We also need to do a primary posterior capsulotomy. And so we cannot do it. We don't want to do a decision or some sort of a YAG or something in some crazy way in the future. We cannot do a YAG on this patient. So we have to plan on doing a primary posterior capsulotomy. And so one of the important points of this talk, in my opinion, is to just get good at that. I want you to get good at that. And I want you to have a hair trigger in the right situation to do a primary posterior capsulotomy because it's so useful. Vicryl suture to get at Kevin's issue. And then I want to talk about, most of us use intracameral moxie, but subtenon's Kenalog is a beautiful way to get around drops. And the guys at Kaiser have done such a beautiful job leading that band. So I want to talk about that. So here's the case. And the actual cataract surgery is so trivial compared to what David just showed us. It's a relatively soft lens. We're just placing some viscoelastic. I don't even know why I'm showing this, just so I can talk a little bit. We're making it, we're going to suture this incision, but we'd like it to be reasonably solid, not leaky. We don't want to have a bunch of sutures. We just want to have one dissolvable suture. We want to make this rexus right at 5 millimeters because we're probably going to capture the lens. And so we don't want to make this huge. We want to make it exactly 5 millimeters. So whatever tricks you have up your sleeve to make it 5, if you've got an accessory on your scope or some other technique, but we're able to get it at about 5. This is a very soft lens. And so the nucleofractus is absolutely trivial. We're just going to hydrodissect, hydrodelineate, prolapse it up, and suck it out. We're beginning to think about what lens we're going to place. We're going to use an MA50 lens, which is a great 3-piece lens, which has a 6.5 millimeter optic, which is beautiful for capturing because we're planning on doing a primary posterior capsulotomy. And so the way I like to do that is to first remove the lens material. The whole time you're doing this, you're thinking that the primary posterior capsulotomy, you're thinking we're going to keep this chamber formed. So we're going to put some dispersive viscoelastic here. We're going to make our incision a little bigger because we have to make it bigger for the MA50. Here's the MA50. The only thing in the MA50 is just get good at putting this in. I know most of us are so used to putting single piece acrylics in, but you have to be able to do this in a pinch. Usually your technicians don't know how to do it. And so you've got to know how to do it. Make sure you protect the plunger if you use this device. But just get so you're good. It's so easy to practice this on the side. Get so you're good with a 3-piece. We're going to use a 27 gauge needle with cohesive viscoelastic. Use cohesive viscoelastic in this situation. We're going to pierce through the posterior capsule. Simultaneously, we're injecting cohesive viscoelastic. And what we're doing is we're pushing the anterior hyaloid face posterior, but we're also keeping the posterior capsule from folding over, because the hard part about doing a primary posterior capsulotomy is that it keeps folding over and you can't grab the posterior capsule. But if you just use that cohesive viscoelastic, it's so easy to do it. It kind of pushes it forward a little bit. It makes it more behave more like an anterior capsulotomy. But most importantly, it stops it from sort of folding over into the space, burger space, or whatever is behind the posterior capsule. In a perfect world, this would be the exact same shape as the anterior capsulotomy. This one was a little bigger. If it's the same size, you can capture the lens with both of the capsules. In this case, we just captured it with the anterior capsule. So here's the MA50 going in. Sorry, it's a little bit out of range here. And we're placing this MA50, which again, I love this lens for this situation because the optic is so big. And so we're just going to prolapse it back, you could prolapse it all the way back behind the posterior capsule. I didn't think we needed to in this case because, and I thought it was a little small. If it was a younger patient, you'd have to do that to prevent the eye capsulotomy, like a 5-year-old or something. You have to go all the way back. But in this patient that's 45, you won't get a PCO with this. Now we're going to use a 10-0 vicryl suture. This is a great trick. These vicryl sutures are great because they dissolve on their own, so you don't have to remove them. Since we lost our sealant, this is what I do. We're going to place a little moxifloxacin in here, and now we're going to use 4 milligrams of triamcinolone in the inferior conjunctival, subconjunctival space. And I'll talk to you about the details of that in just a second. So that's the technique that I use. I'd like to get some opinions. Let me just go and just show one more slide, and that is, I just want to highlight Neil at Kaiser, Neil Schorstein. He has done so much work on dropless surgery in the United States. I love his website, which I cited there. But basically, what he recommends with a lot of experimentation is to just put 4 milligrams there, and you can do it by either taking the standard 40 milligram per ml and diluting it 4-to-1, and then placing 0.4 cc's, or you can buy the special already dilute 10 milligrams per ml triamcinolone and just put 0.4 cc's in the inferior subconjunctival space. And then there's no need for drops, or there's less need for drops. And patients do really well with this. And it makes it so much easier on the caregivers. And then we just did the same thing on the other eye. And so one of the things to be, get good at doing bilateral surgery, get comfortable with it. And we do routine bilateral surgery at the VA. And so we're used to it. It's not a big deal for us. But when patients are under general, you really consider doing both eyes at the same time, because it's like the risk of being in a plane is mainly the takeoff and the landing, and the risk of general anesthesia is the intubation and reversal. And so just being a little longer is the increased risk is trivial. So again, that's my case. I just wanted to say again, just to highlight how much Alan meant to me, what an inspiration he was to me, and I just feel like Alan would want us to fight for these people, and this is the sort of my thinking when I encounter one of these patients. It's going to be a lot of work. We're not going to make any money. We're gonna lose money galore on this. It's going to take a lot of work. There's going to be 1 million phone calls with various lawyers and legal people. The nurses are going to get all upset about all the different things we're doing, but it's worth it. It's worth it to fight for these folks that are sort of forgotten. Anyway, thanks for any questions from the panel or suggestions.
That was a great presentation, Tom. We're going to move on pretty quickly, so maybe just a quick comment from each of the panelists. Bruna, do you want to go first?
Yeah, I loved how you resolved this case. And I always remember how this cataract surgery will impact not only vision, but the interest in the surrounding and like the life as a whole of this patient. Many of the things that you described in this specific case is our routine when we're operating kids. So I also do a lot of congenital cases, and with the exams under anesthesia, the only thing to remember is that you have to have the lens that you're going to place with all diopters available for you in the day of the general anesthesia. With regards to triamcinolone, it's a great way of not needing to use steroids drop in the postoperative. The only thing is that I do it intracamerally in kids, and in this case I would have done it intracamerally, but it's wonderful also subconjunctivally. The intracamerally, we just have to remember that it needs to be preservative free for sure. So just be careful if you're going to start using triamcinolone, if you're using it in the eye, for it to be preservative free. But congratulations, great case.
Yeah, so Bonnie?
Yeah, also wonderful case. I have a quick question, if you can elaborate, Tom. So for those in the audience that don't always do a posterior capsulotomy, can you share your pearls? So you described that you use cohesive on the actual needle to start, but to fill your capsular bag, what type of dispersive or cohesive viscoelastic do you use? And second, how do you remove your viscoelastic after you've placed the IOL, since you already now have an open posterior capsule?
That's a good question. That scared me like crazy the first few times I did this. So, number one, I fill the bag with cohesive viscoelastic like usual. I place dispersive viscoelastic at the wound like usual. And then I go in with a syringe of cohesive viscoelastic that has a 27 gauge needle attached to it. And then I focus down to the posterior capsule. And then simultaneously, after going through the posterior capsule with a needle, I inject that cohesive viscoelastic into the space. Maybe it's burger space, but the space presumably between the anterior hyaloid and the posterior capsule. So then place the lens as I showed. I was super worried about that cohesive viscoelastic. The first time I did this, I didn't even have the nerve to check the pressure. I told the chief resident, go in and check the pressure. I'm too scared. I sat in another room, and because it was like an 8-year-old young girl, and I thought the pressure's going to be sky high, and I'm going to have to explain this to everybody. The pressure was fine. The pressure is just fine. I think the problem with leaving cohesive viscoelastic is when it's in front of the lens or in front in the anterior chamber. But when it's in the posterior chamber, behind the lens, it surprisingly causes no problems with pressure. So I would assume, and I would be skeptical if I were you, Bonnie, and I would expect you to be scared the first few times you did it too. But it just doesn't seem to matter. And I've always thought that you should never leave it. I think the difference is because it's behind the lens. And the cohesive is better at sort of cleanly pushing the hyaloid back and cleanly lifting the capsule up a little bit, posterior capsule up a little bit, than would be visco.
Kevin, real short comment so we can move on.
A beautiful case. I think probably the only thing I would have done differently is I would have probably put the lens inside the bag rather than putting the haptics in the sulcus and capturing it. But I think you can argue this both ways. I just would have done that. Because you had a beautiful posterior capsulotomy. There's no reason not to stick it in the bag completely.
And Tom, we had one audience member asking, what about placing the IOL first and then doing the posterior capsulotomy?
I think it's reasonable to do that. I mean, as long as you keep your chamber form, you have a little more space without the lens in the way.
Great. Well, thank you, everybody, that was obviously a great panel discussion on a complex patient. Our next presenter will be Bonnie Henderson, and she's going to present a very advanced cataract.
Okay. Thanks. So once again, thank you, David. Thank you, Hunter. And thank you, Lawrence, for organizing all of this. And it's such a pleasure to be here. I also wanted to share something that I thought would be near and dear to Alan's heart, which is when we deal with advanced cataracts, whether it's in our country or around the world, I think we need to have a variety of techniques that we can really rely on. And manual small incision cataract surgery is really something that Alan has spent his career really teaching and teaching all of us how to do it well. So I just wanted to really honor Alan by showing a case that was a terrible train wreck for me. So I wanted to share it because I think it's always much easier to learn from mistakes than to show a perfect case. So I have, let me see if I can forward. Great. So I have no financial interest on this. And I just wanted to share a couple pictures of Alan. He has already been mentioned, he was an amazing mentor and a role model for many of us, myself included. And what I loved about him was he was such a wonderful, warm person, but he was also very adventurous and never afraid to really jump in and roll up his sleeves and get dirty. So this is for you, Alan. So I'm going to fast forward a little. This is already double speed, but in interest of time, I'm going to fast forward a little bit. And I had just, gone to Aravind and learned under the amazing Dr. Haripriya Aravind how to do M6 or manual small incision cataract surgery. And I became interested in this early on because as I was teaching residents, we would run into trouble and they'd have to convert. And I found that it was really great to not just know how to do a large incision extra cap, but also to learn how to do a small incision manual surgery. So I had spent time at Aravind. I did cases under Haripriya. She's amazing. And I'm going to pause while I'm speaking a little bit. So she's an amazing amazing surgeon, amazing teacher. She's so patient, and I felt pretty confident that, okay, I'm a competent cataract surgeon before this. I learned under her. I did some cases with her. I felt pretty good. This is my first case after I came back in the US by myself. So I have this very dense cataract, and I thought, perfect, this patient will probably do well with manual cataract surgery. So I'm going to keep playing the video. And the first thing that I'll point out is you'll notice that the pupil is kind of small. And so I thought, well, it's okay. You know, I felt it's not that small. It'll be fine. I'll blow it up with viscoelastic, should be okay. It's large enough that I'm going to try to make as large of a capsule opening as possible. I'm comfortable doing a continuous curvy linear capsulorhexis instead of a can opener, for example, or even a V shape. So I thought that's fine. And I learned at Aravind, a lot of the doctors do a CCC. So I'm going to try to make it as large as possible. So I went, right along the side of the pupil, and I'm trying to find the actual edge of the rhexis to do the hydrodissection. So I'm going to just highlight all the mistakes that I made. So first of all, as I was hoping that the pupil was large enough, that's my first and largest concern, is that pupil is just too small and that lens is just too big. So I am trying to hydrodissect, and now I'm trying to mobilize the lens and prolapse it into the anterior capsule. So I am trying in vain with viscoelastic. Now I'm using a cystotome to use the needle to try to move it along. I'm trying to prolapse it up. I've put in lots of vials of viscoelastic. I'm trying to get it underneath, and I'm trying to mobilize it around, shift it here and there, and I'm really struggling. So I thought, okay, well, let me try this one more time. I think it's going to work this time. And again, I'm struggling and struggling and struggling. So I'll keep fast forwarding. So I thought, well, maybe I don't need it. Maybe I'll just use my irrigating vectors to go in and toe in. Okay, now I'll use a second instrument to try to prolapse it up while I use the irrigating vectors. And that's not going to work because the lens hasn't prolapsed out of the capsular bag. And I thought, you know what? I'm a phaco surgeon. I know how to phaco this. So I'm going to use the phaco on a high vacuum to hold on to the lens and actually prolapse it up. So I'm going to actually hold on with vacuum, prolapse it up, use a spatula on the other hand to try to bring it up. And I'm really trying to rotate this. So I thought, okay, maybe I'll just debulk it. So I'm just going to eat up some of the equator. Let's make it smaller, and let's hold on with vacuum. I'm going to try to dial it out, and maybe I can just flip it. So, hey, look, it's kind of working. I'm trying to maneuver it. I'm flipping it up, and it's kind of working. So I'm hoping, and I'm struggling. And now I'm going to use more viscoelastic. And you can see it's just such a struggle. All the beautiful cases that we see our wonderful colleagues around the world doing this, effortlessly. In the first case, it was much more challenging than I thought. So here I am. I finally got it out. Wonderful. Yay. I'm so thrilled. So I finally have this. As you can see, it's a pretty large lens. Now I've got my irrigating vectors. I think I'm good. Oh no, look, I'm not good. So what I'm noticing is iris is prolapsing. So why is the iris prolapsing? Two things. Number one, my scleral tunnel, my groove was probably entered in too prematurely. I didn't use my keratome enough to actually make a longer groove. So I'm really struggling with the iris coming out. Secondly, my incision was just too small. So as you saw, I went in with a keratome and I widened it further in order to make it a little bit wider so it's a bit easier. So now I'm able to take it out, and I struggled. It came out, but as you can see, I really made a mess of the iris. Fortunately, I'm sitting superiorly. It didn't matter as much, and the patient did well. But I just really wanted to show some of the things that I struggled with, because I think when you start doing manual cataract surgery, it's really good to know and be aware of the problems that you can run into. First is really the pupillary dilation. So important. So in hindsight, probably what I would have done was made sure I made that pupil larger, whether it's with iris hooks or the ring. Using a ring is sometimes hard because you cannot prolapse a very large lens through the ring into the anterior capsule. So I think capsule hooks or iris hooks are a little bit better, not capsule hooks, sorry, iris hooks are a little better in that way. You can also do sphincterotomies by actually making multiple small cuts and actually dilating it there. Make the scleral incision wide enough to ensure that lens can prolapse without having to really struggle and then without damaging your corneal endothelium. Make sure the capsule opening is obviously large, and beware if the patient has a floppy iris to begin with. So in hindsight, again, I look back at the chart, and the patient was on Flomax, had a small pupil, probably because he already was having some iris issues from the medications. And so again, in hindsight, lots of lessons learned. So just wanted to share those. So thank you.
Thank you very much, Bonnie. I mean, that's very generous to share a case like that because I think we learn more from that, and it just shows that the manual small incision, like all surgery by good surgeons, looks so easy, but it's not. So there are a lot of great points there. Who wants to start on our panelists? We have Dave, Tom, Kevin.
Well, I just want to say, before Bonnie got so famous, and became such a a CEO kind of person, she used to do these great videos where she would ask us for videos just like that, and she would sync them to music, and she would also ask for everybody else's complications. You remember that? Like mine, she'd ask me. I'd give her like 10 of them. Bonnie, you need to put that to music like the old days. Well, the only thing that my residents make fun of me because I do what's called the world's most expensive extra cap. And what I do is I make an incision kind of like a small incision, and then I use a my loop and split it in two. And then I pull out the two halves, and then I make another incision and use my IA. And then I put in the fancy lens and a capsule tension ring stuff. So I take a procedure that David showed us cost like $25 and made it into like a $2,500 procedure. But anyway, I think it's really hard. I mean, the thing that's funny about small incision extra is, to me, it's extremely hard to get the incision right, to get the rhexis right. It's funny that at Aravind they teach that before they teach phaco, because to me it seems so much harder. Anyway, thanks for sharing that.
I thought that was a great case, and I've been through those more times than I would like. I do think the incision size, I agree with you that almost every time I do one after I haven't done them for a while, I make my incision too small to start with. And we get so used to getting smaller and smaller incisions, and one of my partners is doing 1.8 millimeter incisions, and so that 8 seems huge, but making it bigger so everything comes out smoothly and it seals just fine. The comment about the Malyugin ring, I did have a partner convert to an extra cap with the Malyugin ring in, and then got the lens loop under the nucleus, and then was stuck in the eye because she couldn't get the lens through, and ended up having to go and cut the Malyugin ring to get enough space to pull that lens out. And she was just sitting there holding that thing, hoping not to drop the lens onto the retina. So capsule hooks are definitely the way to go on those.
I agree with that. I showed a video at Dave's Spotlight Symposium where I made the mistake of putting a lens loop through a Malyugin ring. I got this big old nucleus into the anterior chamber, and then I was like, I couldn't get anything out of the eye. It was like putting your hand through a link in the fence, grab an apple, and then you can't get your hand back because you're holding the apple. It was terrible. I ended up cutting everything, and I finally got it out. The only thing I think, these sometimes when the nucleus is so dense, it's basically nucleus out to the capsule, that you're just not going to prolapse that nucleus through any size capsule or rhexis. And you like to kind of figure that early on in the procedure, and then just take a cystotome and just do little nicks in the capsule and just basically convert your beautiful capsule rhexis into a can opener, and then then you'll get it up. Then the question will be, was your incision large enough to get it out? But it was a beautiful case, and I appreciate, Bonnie, you showing this, because these are all the classic mistakes, all of the classic.
Yeah, I did that for everybody. I just wanted to make all the mistakes in one case to have a good teaching case. So
I would just add, I think that when we learn these cases, this was tough because you had a bad lens, a rock, you had a small pupil. And so, to those in the virtual audience, I do these, on more routine cases as you're learning. And I realize that they aren't necessarily the ones that will need this, but maybe it's a traumatic case or something like that. But just to echo Dave Crandall's comment, I also am always too small in the incision. I also would do a can opener, I do them all the time because these are usually really bad cases. That's why you're going to this. And I don't think there's any great advantage to the Rexus, although just as Bonnie said, so many of the Aravind surgeons are doing them because they're that good. And then, IFAS changed the way we handle pupils. Before that, I think we all remember we would always do sphincterotomies and stretch the pupil. That wouldn't have worked here if this was an IFAS small pupil, but that really is what I go to with an extra cap, and it just weakens the sphincter enough that it's just easier to prolapse things through. But thank you again, Bonnie, for that terrific case. We're going to move next to Bruna Ventura, and Bruna's going to discuss an IOL exchange.
Thanking everyone, and you, David, specifically for the invitation to be here honoring Alan. Every moment we had and shared throughout the numerous meetings we were together, he always was someone that takes the time to teach in the small and big cases. So I'm very, very happy to be here. I'm going to be speaking on an IOL exchange technique that I recently used and liked a lot. These are my possible conflicts of interest, but none of which are important for this case specifically. So this woman, she's a 52-year-old woman that had undergone refractive lens exchange in her left eye in another clinic 6 weeks before coming to consultation with me. So she had implanted, her doctor had implanted a trifocal toric IOL, and she said that she used to wear glasses, and she was completely dependent on glasses, but now she sees well, but without seeing with quality. So she's like, it's driving me nuts. I can't continue with this lens in my eye. And one of her big things was, it was Christmas here in my city. And in Christmas, all the Christmas lights at night, she said, I can't drive in the city. Like, it's driving me nuts. I can't do this anymore. And I'm like, well, let's check your vision. Let's take one step at a time. I am not a surgeon that I rush into a lens exchange. I am very cautious with it because the patient usually has very high expectations with any of our cataract surgeries, and especially patients that had refractive lens exchange. So she was in the operated eye. She had a 20/20 vision, J1, with great speed. But she's like, I'm like, look how much you're seeing, and compare it with your right eye that hasn't been operated. And she's like, well, yeah, I can see the 20/20, like the small letters near and far, but it's not with quality. And I am crazy with the lights. Like, I can't go ahead with this. And looking at her exams, so these are exams that I took when she came to me. So these are our post-op, so it's pseudophakic, but we can have a great idea of her eye. So we see that she has a very significant amount of astigmatism, almost 4 diopters of with the rule corneal astigmatism, a regular symmetric great bow tie astigmatism, very small amount of corneal aberrations, and also a great pupil for diffractive lens. However, she did stay with a residual astigmatism, and my suspicion was that was the main cause of her big symptoms. I tried lubricating her and improving her ocular surface, and she came back like 2 weeks later, and she's like, I'm still very unsatisfied. I want to take this lens out of my eye. So before proceeding into saying which technique I used, I wanted to go through the panel to hear which technique we are going to take this lens out. So which technique do you prefer for lens exchange?
If it's an acrylic lens, my preference is to refold the lens inside the eye. I think you just put a cyclodialysis spatula through an opposite side paracentesis. Once the thing is in the anterior chamber, and it's very easy to take old lens insertion forceps and just fold it over the cyclodialysis spatula and turn it 90 degrees and pull it out. If it runs away from you, then of course you would cut it out. but almost all the trifocals are acrylic, so they're usually very easy to refold. In a warm intraocular environment, the lens folds very easily. If it's in a cold environment, it can sometimes be difficult, like in the operating room. But inside the eye, it's super easy to refold them. So that's my preference.
Dave?
I usually sort of roll them. Uday Devgan showed the technique where you grab it with a tire, put a cyclodialysis spatula over the top of it, and just twist it until it becomes small enough to come out of the wound.
Wonderful.
I usually just cut them out. Bonnie was the first one, just to give her proper credit, the first one to describe the idea of crimpling up those single piece acrylics and pulling them out. So while she's here, we might as well give her credit for that. But I usually just cut them because I'm so used to it, and I'm good at it. And this is not a thing I do a lot, and so I just want to not worry about it. I just want to do something that I'm slick at. And the biggest problem to me is not how do you make the lens smaller, but how do you get the lens out of the bag? I mean, that's the big problem for me. Although this is out, right? So it's not going to be too bad.
Yeah, that's true. So I did use the twist and out technique, which was already pinpointed by you guys here. And I wanted to show you the video of the patient. Let me just play this just a second. Okay, here. So I start by injecting viscoelastic and releasing the lens. It's very easy to release this lens very gently, since it was the very recent, the first procedure. Here I'm injecting a monofocal toric lens in the bag. It's very useful to protect the capsular bag, the posterior capsule, while we're doing all the maneuvers. And here is how we do the twist and out technique. So first, we exteriorize one of the haptics through the main incision, and then I used a McPherson forceps. And the big trick here is for us to have our hand in a supine position. This is key for us to have a good amount of rotation during this next step that we're going to see now. So I hold the lens near this haptic that's out of the eye, and then I use my spatula, my iris spatula that we all have, to hold the lens in the same plane while I'm rotating my right hand and letting the lens fold. And you see how easily, as you mentioned, Kevin, it comes out very gently and with no stress. So again, here I am positioning my hands in a supine position while my spatula is holding the lens horizontally. I rotate my hand counterclockwise and let the lens fold. While it is folding, you pull it gently through the main incision, and it comes out beautifully. Here we have the other lens in the bag already. At the end of the surgery, we see an aligned monofocal lens. I put in a suture. I always like to put in sutures in these cases that I want to have a complete control in the first hours of post-op and no surprises. So in the other day, she had a transparent cornea, already a 20/20 uncorrected vision, and very, very happy. She's like, I didn't even believe that I could not see all the lights in a very weird way. And the big point here, besides the one that I'm going to speak, is in the pre-op, I showed her that she was going to lose that near vision. That needs to be very, very clear, because it's a give and take. So, okay, we'll improve the dysphotopsia, but you will lose the near vision that you never had it. So you have to make that very clear. Some points with regards to this twist and out technique, it's very, very important for us to always protect the endothelium throughout the procedure. The incision diameter, although it was described, the original technique was described through a 2.2 millimeter diameter incision. I couldn't get it out through a 2.4. So I enlarged it slightly, but I did enlarge it, especially if you have a high diopter lens in the bag that's coming out of the eye. You might consider increasing your incision's diameter a bit. And the main point here is to pay very close attention to the decimate membrane in the incision. because I showed you an edited video of the surgery, but I had to redo that maneuver, I think around 4 or 5 times until I grasped. It was my first case also doing this technique, applying this technique. So while you're doing that, pay very close attention to the disseminate in the main incision, because you can stress it with this counterclockwise motion. And that was everything that I wanted to bring to you. And thank you again for this opportunity.
Great. Thank you, Bruno. What did you do for the other eye?
So the other eye, she's monofocal toric also.
And did you do mini monovision, or did she want a distance in both eyes?
No, distance in both eyes. One thing that a mini monovision could have been done, but her main complaint was, I didn't even want to get rid of my glasses. I just wanted to have good vision. And then I was offered getting rid of my glasses, but no one said I had a trade-off. So with her glasses, she was completely dependent on them, but she had a great quality of vision, which she did notice when she changed to a diffractive lens. So one of the points that is very important educationally talking about this whole case is also to manage the expectations and always ask our patients, like, okay, what do you want to do? What is your expectation with this surgery? Because sometimes most of the times they don't understand there is a trade-off, especially with refractive lens exchange, when the patient has wonderful quality of vision near, far, with glasses, for them to understand that it is a trade-off. You can be glass independent, but quality, you will notice if you're very picky. Most of the patients today, what I feel is that they're okay giving into a bit of the quality to improving the independence, but that needs to be said. That needs to be very clear out on the table since before surgery, for sure.
Hey, Bruna, if you would have not needed the toricity of the lens, would you have considered placing a silicon lens like an Li61 or something like that to maybe lessen the odds of continued positive dysphotopsia?
Instead of explanting the lens?
No. It's so after you decide to make the exchange, if you didn't need the toricity of the single piece acrylic, would you have used a 3-piece silicon lens, which is thicker, has a different index of refraction, and would make it less likely that you have positive dysphotopsia? Something like an Li61.
Yeah, I actually have never used a silicone lens in my life, so I wouldn't think of that solution. And I was very confident that the source of her problem was the residual astigmatism, the residual refraction post-op. So I was, and like all her maps, all her measurements were so on spot that I was very, planning the surgery was easy. Like, I wasn't stressed about that part. I was just very confident in telling her that this was another procedure, that there's an improvement in risks and all of that needs also to be said. Positioning the monofocal lens before explanting with whichever technique you're using if you're cutting, if you're doing another technique, is another great tip for you to protect the posterior capsule while you're doing your maneuvers.
But you do want to be careful not to damage the lens that you implanted when you're cutting the new, because then you're removing a second lens and putting a third one in. Tom, I do what you do for if they don't need the toricity. I do like the Li61 for those, just to reduce the chance of the dysphotopsias. One thing I want to point out with this twisting technique, because I do a couple of these a week, unfortunately.
Really?
Yeah. No, we have a lot of people putting in a lot of multifocal and extended depth of focal lenses in patients that really, as soon as you meet them, you know it's not really the appropriate choice for that patient. I found once they get up to the higher diopters, when you're getting up to 30, 31, I usually just cut those unless I need to have the lens intact when I remove it, because that extra thickness is hard. It's not just harder to get out the wound, but it is harder to do the twisting because there's a little more resistance. And like you, I do extend my wound a little bit. It's about a 2.5 when I remove these lenses. The other thing I will mention is you obviously don't want to do this with a 3-piece lens, because that trailing haptic is going to swing all over the place, and it's either going to create a desec, an iridotomy, or a vitrectomy for you. So those have been my pearls in this. Also, if you use a straight tire, I think the hand positioning is a little bit easier. Just to twist it straight around, it slides straight out instead of turning to the side a little bit as you're rotating it.
Yeah, that's a great comment, Dave. I tried my straight tire, and the thing is, you have to pay attention to get the thinnest instrument you have in the wound.
Mm-hmm.
Mm-hmm.
There is a difference when you're removing
Right.
these acrylic lenses. There are two different sort of methods for manufacturing. One uses constant optic diameter, optic zone. So that'll be the Alcon, for instance, in the United States. And then there's the constant center thickness approach, such as Johnson & Johnson Vision. So if you have a constant center thickness lens, like J&J, it's the same thickness no matter what. So the dioptric power doesn't really matter. They're all the same. With the Alcon lenses, yeah, the higher the power, the thicker the lens. You also have a different approach for different materials. So the acrylic lens is the easiest to get out. Silicone lenses, in my opinion, are the hardest to get out. They're so thick, and it's really hard to grab them. They want to run away from you, from your scissors. You really have to get tooth forceps in there to hold on to them while you're cutting them, and they're really thick, and you have to open the scissors really, really widely. Collamer, somewhere in between. And then some of us tried to cut out these thermoplastic lenses, like the memory lens from years ago. Don't even try. Just open up the 6mm incision. Not going to happen. You're not going to cut the thing. So you have to have a different approach for each material.
Let me ask Tom, you the final question on this section. You mentioned trouble getting the lens out. What would you say is a limit? You know, this is a patient that is unhappy. What if she came back to you after a year or two? Is there a limit that you have?
I don't think there's a limit, but I think you change the consent. I think you have to change the consent if there's been a YAG capsulotomy, and you have to change the consent the longer that the patient's had the lens. But I don't know if there's ever a time you would say no, but I wonder what happened. You know, what is she? You know, has their attitude changed in some way about light, or what? Why is this gone on so long? And that would make me nervous. But I think if the posterior capsule's intact, years later, I've taken these out. You have to be very careful. And one little trick, just real quickly, you can use the MST capsule retractors to support the capsule while you try to get those haptics free. Because the big problem is the bulb at the end of the Alcon lenses, and then some other parts of other lenses that stick a lot. But just be real careful, and it's shockingly easy if you just place an MST retractor right in the area of that bulb, and then use viscodissection. You can often get those lenses that have been in there a long time out, or you just cut the haptic off.
Yeah, 25 years is the record for me removing one. And to answer that question, Tom, the reason it was one of our technicians. She had a resume lens, and she hated it for years. But she waited until she was comfortable with seeing me do so many exchanges that then she wanted it out.
That person with that kind of persistence, I'm guessing you did not give her a bonus for 20 years and she's stuck in there, hung in there with you.
But that is
that true?
Yeah.
That is the profile. I mean, there are people that it just was never offered to them because their surgeon was not comfortable with that. And maybe they did a monofocal in the other eye and they still notice that. So I think the lesson is if you're going to do diffractive IOLs, you should be able to or be willing to refer the patient to make it reversible. Well, we have one more presenter, and we're going to turn it over to Kevin Miller, who has a traumatic cataract.
Well, again, thank you, David, for organizing this. And it was, everybody said this about Alan, but I've known Alan for 30 years and conferences all over the world. Amazing person, human being, amazing teacher, great surgeon. I see a lot of his patients actually at UCLA, even now. It was just a phenomenal experience in getting to know Alan. So I'm going to show you a traumatic cataract. I have some financial interests. They're not all that relevant. So this is a 69-year-old man who had an injury to his right eye from a battery explosion in the 1970s. At the time, he was treated with some eye drops, but didn't undergo surgery. The result of the explosion was, as you see on the right side, it was a pupil sphincter tear, a zonular dialysis, and then eventually a traumatic cataract. When he saw me several decades later, his best corrective visual acuity was counting fingers at 3 feet. Here's what he looks like on dilated slit lamp photography. So you can see the zonulopathy, you can see the sphincter tear, and the cataract. So here are my questions. Bonnie, how would you approach cataract removal in this case? Would you do an intercap? Would you do one of your manual small incision extra caps? Would you phaco this one?
At this point, I would be trying phaco. I would want to see how well that lens is sitting. But if it's really just a small area of zonular dialysis, I think it could be managed by phaco.
David, this is David Crandall. Do you agree with Bonnie? Would you phaco this thing?
So I had one of these on Thursday, almost exactly like this 50-year-old injury with a black cataract that I did attempt to phaco and then converted to a small incision extra cap when I could not make any progress with it. Mm-hmm. Which is usually my approach with these. I'll make an incision like I do for a small incision extra cap, go and centrally try to phaco it, and if I can't, then it's 10 seconds for me to convert.
And do you think there's going to be vitreous in the anterior chamber with that zonulopathy?
There's a good chance, especially since it's traumatic. I think there's a good chance of it. And the one I had yesterday, I did, and I started with a vitrectomy before I did the rest of it.
Fair enough. So I agree with Bonnie and you, David. I thought I could probably phaco this. So my first step was to fashion an infratemporal Hoffman pocket so that later on in the procedure I could suture a capsule tension segment to the sclera in that meridian with the greatest zonular loss. So here we are. This is sped up 4 times. So here's me creating a Hoffman pocket down there where the zonulars are missing. All right. So then I performed a vitrectomy using both the pars plana and the anterior approaches. I use a diamond knife to do my sclerotomies. A lot of people use an MVR blade. So do the posterior approach first, try to sever the adhesion between what's in the anterior chamber and what's in the vitreous cavity. Now, this is the actual procedure, went way longer than that. I've probably spent several minutes in there cleaning out the vitreous. So once we've amputated the vitreous connection, then I remove the vitreous in the anterior chamber. And of course, you have to be super careful not to capture the iris with the retractor. So that went on for several minutes. It wasn't just a few seconds I showed. So next steps are going to be the incision, the capsulorhexis, and the hydrodissection. I use this Mastel diamond blade pretty much for everything. It's just a beautiful knife. You can do every step of the procedure, including relaxing incisions with it. I didn't think that this would be a good femto case. Most of my cases nowadays are femto, but this was just all manual. Okay, there's the hydrodissection. All right, so Tom, would you attempt rotation of the nucleus at this point, given the zonulopathy?
I don't think I would yet, Kevin. I mean, I think it's a miracle you've gotten that rhexis done so beautifully without any hooks or devices. I was kind of surprised. I thought for sure you're going to have to use an iris hook or something to support and give you a counter. But I would place an MST retractor now if it was me, because I don't want, the rotation is such a risky business. It puts so much force on the zonules. And so I would just go ahead and place probably 4 MST retractors. You could argue possibly just placing 2 in the area of the known weakness, but there's like the known unknowns and the known unknowns, all the, the known knowns and the known unknowns. But anyway, there's zonule, the zonules are weak everywhere. And so I probably would go ahead and plan on 4 and just do it and get it all secure. And then I would very carefully do some hydro dissection and very slowly rotate that nucleus.
Okay, so Tom would put in 4 capsular retractors. Bruno, what would be your next step?
I would also do that, and then I would use 2 hooks to rotate this nucleus. So if you notice, when we use just one instrument, if it's your OVD cannula or a hook to rotate the nucleus, we usually push it down. So I like in all my routine cases, I do this, and especially in this case, I would do this. I would use 2 hooks, and then your movement is always in the same plane, and you stress less the zonules.
Okay, so Bonnie, you see the question. Do you agree with Bruna? You do the retractors, then 2 hooks in there, or what would you do?
So I would do the retractors. You can also even put a hook inside an odd segment to actually give a little bit more of a support. And then instead of rotating, I would actually try to prolapse the lens out of the capsular bag so that I actually don't rotate it at all, if that's possible.
Okay, fair enough. So
And then I would do that with one hand behind my back and upside down and doing a handstand. No.
okay, so I did put a capsular retractor in, but I thought I could get away with just one. So I put one. I figured I can always put more. So here I am putting in a single capsule retractor in the area of the zonulopathy. And I thought at that point I had reasonable, zonules elsewhere to proceed. So David, would iris hooks have worked just as well here? Maybe this is David Chang, of course, you can chime in too. Would a bunch of iris hooks work just as well as a capsule retractor?
Yeah, they can work, but the problem is the tips of them are not polished, so they do have the risk of ripping through the bag. And I also prefer capsule hooks because they go all the way out to the equator of the capsule, whereas iris hooks will just give you basically support at that first millimeter or so. So in a pinch, they can be used, but it's definitely not as safe. There's more of a risk of tearing your capsule, and then you're going to have trouble with OMED segments and CTRs and everything else. So you're more likely to have to take everything out and do some kind of other either scleral or anterior chamber lens situation. So they can be used. I have used them. I've gotten away with it. I've gotten burned by it. So I much prefer I prefer the MST hooks, but the Makula hooks will work as well.
I think we've all been burned by the iris retractors. So Bruna, Bonnie earlier mentioned putting a capsule tension segment in and then hooking that with an iris hook. Do you think that's reasonable?
I think that's reasonable. If you still have unstable lens, we could do that. Another thing that I like is that if you do have an unstable lens that from what we saw, you probably do have, we could place a ring in the capsular bag and then also use that to stabilize in addition to the capsular tension segment with the iris hook. I like that strategy also.
You would do that before removing the nucleus? Because then you're going to really trap a lot of cortex, right?
It really depends on how unstable is the bag. If it is very unstable, yeah, I would do that before. If not, I would probably save that for after cortical cleanup. Okay,
and Tom, so you were voting for 4 capsule retractors before. Now that you've seen what happens when I just put one, and do you still think we need 3 more? Or do you think we should just proceed?
Well, I want to see what happens when you just have one, but I would have put 4. But the other thing to get to Bruno's point, I think you have to be comfortable placing a capsular tension ring in early. And the key to that is using cohesive viscodissection between the anterior capsule and the lens so that you don't trap cortical material. And so you use cohesive viscoelastic and you really get a great dissection way wide of where you're going to put the capsular tension ring in, and make sure that you just put the ring just under the capsule. And usually you can avoid capturing that or trapping that cortical material if you use the cohesive viscoelastic before you place it.
Fair enough. So I decided rather than even attempting a rotation of the nucleus, I would just do like an in situ divide and conquer. So there's no nucleus rotation. So I'm going to blast through this. You're not going to, it's highly edited. But I was able to just kind of do a kind of like an in situ divide and conquer. So there's actually no nucleus rotation whatsoever here. And the capsular bag remained relatively stable. So there's the nucleus out and cortex out. And so far, I don't have a capsule tension ring, and so it should be relatively easy to get the cortex out. But you can see there's stria in the capsule from where the hook is. Little difficult to get some of that stuff out of there. But I was able to get through at least that portion of it without additional hooks. So, Bonnie, this is where we are. What would you do next?
Sure. I still would put in a capsule tension ring, and because long term you really want to make sure it's stabilized. It depends on how many clock hours. It looks like it was fairly large, so probably suturing it in would probably be a good idea. If it was under 3 clock hours, I think without suture it would have been fine. So
Yeah, it's about 5 clock hours, I would say.
yeah.
So David, do you agree with Bonnie? Next step is a capsule tension ring?
Yeah, I'd put a capsular tension ring in next. Or, I mean, I usually do capsular tension ring and Ahmed segment, but you could also do a Sione one.
Okay. And so that was my next step. I injected a CTR and removed the capsule retractor. So one of my pearls is you need to make sure you've completely filled the bag with OVD, preferably a highly cohesive OVD, before you inject or place the CTR. I pretty much 100% of the time I inject these things. I was involved in the capsule tension ring clinical trial years and years ago, and I've pretty much learned to inject CTRs, and I've pretty much injected them ever since. There's a trick to doing it. You want to kind of inject as far, if you're right-handed, as far to the right as possible, lay it out, and then for 180 degrees, just lay that thing out. They always say inject into the direction of the zonulopathy. If you have support, you don't have to. So you see how I'm angling the thing around as I inject. So I pretty much always inject now. So now we've got some support there. So I'll take out the capsule retractor. And this is my way of removing capsule retractors. I just bring them out through the phaco incision. It's just pretty easy. Okay, Bruna, now what?
Now, from my video here, I think you still have like subincisional cortex. If you do have that in this moment, I would get a cannula with BSS and aspirate that very, very gently, because you're winning the game. And this is a very tough case. So as gentle as possible in the next steps, because everything can change very quickly. So I would aspirate this subincisional cortex and then my lens.
Okay, so Tom, is that what you do? Next, let's go after the subincisional cortex, or would you do something differently?
I like the idea of cleaning things up, but you don't have to be too worried about a little bit. But I would be super tempted to place a 3-piece in the sulcus and capture it, and not suture anything. I don't know if that's what Bruna meant, but I think you're going to get away with I think you get away with a 3-piece in the sulcus. I mean, David for years has been talking about the power of that technique. I love it. It's amazingly powerful. So I don't think you need to suture anything. I think you can put the lens in the sulcus and prolapse it back.
David, are you in agreement?
Yeah, I think either approach is reasonable. And if for getting that last little bit of cortex for these traumatic cases, I like to just use bimanual IA, or you can even use the vitrector in this case since you already have it open.
What about using anterior capsule polishers to get at that cortex?
You can, and I actually, you ask if I routinely polish, I always polish the anterior capsule. And I usually, most of the places I have the Coke spatula that Epsilon makes, I really like it. It's got a nice long paddle to it. So yeah, I do that in every case.
Hey, listen, polishing this capsule is gilding the lily. This is beautiful. We are so close to being done. Please don't fuss with that.
I'm going to polish the capsule, Tom.
Don't polish the capsule.
I can't help it.
Don't do it.
Yeah, I gently polish the capsule in these cases.
Okay, so I did a little bit of capsule polishing beneath the Hoffman pocket to remove the residual cortex, and then I implanted a capsule tension segment. So here I am polishing the capsule. I just can't help it. I gotta get that stuff out of there. And then I'm going to spare you all the suture passing because it's pretty tedious. But here's the capsule tension segment. You want to make sure that eyelet is above the rexus. We all know that, so we're going to make sure it's above before we cinch it down. And then I'm just tying it temporarily here. I'm just not going to stay there. I'm just temporarily tying it. So Bonnie, does it really matter here if now they got a capsule tension segment, I got a capsule tension ring? Does it matter if the IOL that I put in is 1-piece or 3-piece?
Well, technically no, but I always like a 3-piece in these situations because I think it just gives you more options later on. If it decenters later on, dislocates later on, you can always try to put in the sulcus, suture it in. So for these cases, I think a 3-piece is the way to go. It's a little bit more rigid as well. And so if you are putting that haptics in the capsular bag, it also uses kind of a buttress and pushes the capsular bag apart too.
So Bruno, we now know that you like to take out multifocals. Would you put in a multifocal here?
No, no, but one comment. I'm not like David that's taking out lenses every week. Thank God, this is a very rare situation for me. But I would not implant a multifocal in this patient. I am a conservative. I love multifocals, but I choose my patients carefully, and this wouldn't be one receiving a multifocal lens in my hands.
Okay, I agree with you, but I disagree with Bonnie in that I think you can get away with a single piece acrylic, and so that's why I think if everything starts to go south, I've got a capsule tension ring that I can suture to. But I do place the optic haptic junctions at 3 and 9 o'clock, as Bonnie taught us, to reduce the odds of negative dysphotopsia. So I also couldn't just let the rest of that lens epithelium sit there on the anterior capsule. So I did kind of polish that. Tom's shaking his head. But, okay, here I am putting the single piece acrylic lens in, got the little handshake going on there. So optic haptic junction 3 and 9. Then I'm going to retrieve the Prolene sutures through the Hoffman pocket and tie that down. All right. So David, do we need to suture the iris sphincter where it ruptured?
In these cases, I'm hesitant to do that because you do have the risk of damaging your capsule. It's got a ring and a segment and everything else. And, Sam Maskett really pushes that for if it's a problem, come back and fix it later after everything's fibrosed. It's a little bit safer.
Tom, what do you say?
I agree. I would quit now. You're tired, Kevin. You've been scrubbing so much. You must be exhausted.
Okay, I agree with both of you. So I just decide ahead of time, even if the lens edge is exposed by the pupil, I'm not gonna run the risk of dinging the anterior capsule, having everything split open. Now I have to take everything out. So I'm just gonna put some Myocol in, Mystat, let the pupil come down. It is what it is. And if the patient's not happy, I'll take them back to the operating room later on once everything's fibrosed in, and then I will suture that pupil sphincter. So you'll see what the eye looks like here right at the end after we get some Myocol in the eye.
And the pre-op iris was not that bad. It wasn't like it was a blown pupil. So I think it's fine to leave it. I agree with you.
Yeah. You can tell this is a J&J lens because it's got that peripheral flange region. So there's the notch defect down there in the, and in fact, the edge of the lens was visible at the end of the case. I still decided I'm not going to take the hand in the hole and try to fix it. And in fact, I just want to make sure there's no vitreous over there, so I'm sweeping. I figure I can always go back and the patient wasn't bothered. There was a little notch defect at the very end, post-operatively, and wasn't bothered. So here's what the final appearance looks like. I chose not to suture, as I mentioned, and patient was okay with that. Was seeing a lot better than they were seeing. I think they were 20/20 corrected. I don't remember what the uncorrected vision was. So this is a dilated appearance. This is 2 weeks after surgery. Any last thoughts, panelists?
Beautiful. Beautiful job.
Yeah, beautiful case. Amazing.
Perfect.
David, back to you.
Yeah, Kevin, thank you. That's a good case to end on. We're at our time, so I want to thank our faculty members for some great cases, but even more so some fantastic panel discussion. For those of you in the audience, you can go back and watch this program. All these programs are archived on the CyberSight website, including the first 3. Best to everyone. Thank you for spending part of your Saturday with us. And again, thank you to CyberSight for hosting this great format in honor of Alan Crandall. Goodbye, everyone.